I'm Jordan Mayberry, and I am a physician assistant that has been practicing in hepatology for about 11 years. And I have Patrick Horne, who will be joining me this morning. And we're going to talk a little bit about understanding chronic liver disease and cirrhosis. So excited to get talking with you, Patrick.
Yeah, you too, Jordan. Thanks for having me. Exciting topic, and looking forward to having our conversation.
Yeah. Okay, so let's talk a little bit about our practice and what are the most common causes of chronic liver disease that lead to cirrhosis and why?
So in my practice, I'm at the University of Florida in Gainesville, and so kind of probably similar to yours. I see really kind of the whole gamut, right? I see viral hepatitis, mainly hepatitis C, but also hepatitis B as well, of course. Lots of alcoholic related liver disease. And then the big one is obviously MASLD and MASH. So really see all of that. I see acute on chronic liver disease. I also see things like autoimmune hepatitis, PBC, PSC, really the whole spectrum. So.
Yeah, I agree. In our practice, we treat a lot of the viral hepatitises, so things like hepatitis B and C. But more recently, we see a big increase in patients that are being diagnosed with MASLD and MASH, and then also an increase in our alcohol-related liver disease. I'm sure that you're seeing that in your practice as well.
Yeah, 100%. I think the sort of the trend across the nation is similar to that, which brings in some obvious challenges. I don't know about you, but at least in my practice, not only are we seeing an increase in this, but we're also, a large number of them are coming in, and we're either diagnosing them with cirrhosis or they already come to us diagnosed with cirrhosis. And so that obviously presents an added challenge of dealing with not only the underlying cause of the liver disease or the underlying cause of the cirrhosis, but then also dealing with the cirrhosis part as well.
Yeah, of course. Well, we talked a little bit about these chronic liver diseases, but could we back up a little bit maybe and talk about how these chronic liver diseases progress to cirrhosis? How are these diseases staged? And then maybe once we talk about cirrhosis, maybe we'll talk a little bit about some definitions of cirrhosis.
Yeah, sure. What I see a lot in my practice, let's just use hepatitis C, for example, because I still see a fair number of hepatitis C patients in my practice. There's certainly that small group of sort of the younger IV drug users that we've had, but I still see a fair number of, what would be considered baby boomers, if you will, or at least older individuals. And what's happened is some of them have been newly diagnosed with hepatitis C. Others have actually known they've had hep C for years, but haven't had any follow-up, whether it's lack of insurance or just, they move or whatever the case. And so, many of them have had this virus there for quite a while, decades, and that ongoing inflammation, which can, as you know, can be very, very silent, maybe have elevated liver enzymes, maybe don't. And it's just sort of been sitting in the background and smoldering and slowly causing that inflammation that's been going on. And over time, that leads to the fibrosis, and ultimately we end up with cirrhosis. So I see that a lot. Not only in my viral hepatitis, Hep C patients specifically, but obviously in things like MASLD, MASH, and then, alcoholic liver disease as well, because not only may this might be a chronic issue that they've had going on for quite a while, but, we see a fair number of acute on chronic as well. So I don't know if that's similar to your practice.
Oh, absolutely. Kind of what I discuss with my patients is how important it is for us to stage their liver disease. And when we talk about staging liver disease, we talk about the spectrum of disease. We know these diseases can start as inflammation within the liver, and then over time, that inflammation can lead to fibrosis and then eventually to cirrhosis. So we'll talk a little bit maybe about some modalities for staging of liver disease, but all of these disease states are progressive. And so inflammation being kind of the initial thing that we see within the liver tissue, and then moving from fibrosis into cirrhosis. Once we have cirrhosis of the liver, there's kind of two different buckets that we talk about. We talk about these patients that fit into our compensated cirrhotics and then our decompensated cirrhotics. Patrick, could you talk a little bit about the difference between our compensated cirrhotics and our decompensated cirrhotics?
Yeah, sure. And this is sort of how I also explain it to patients as well. So, our compensated cirrhotics are those who have cirrhosis, obviously. So if you were to do a liver biopsy, you would see cirrhosis on biopsy, but they're not having any of the complications associated with cirrhosis. So they're not having hepatic encephalopathy, so HE. They're not having ascites. They may or may not have esophageal varices, but they haven't had a bleed from those varices. And they may or may not be jaundice. Their bilirubin may be normal. And so, I put that into that sort of that compensated bucket. And then obviously decompensated, I explain, is sort of the opposite, where you've had these complications. You're having signs of liver failure is how I normally put it. So you might have jaundice, you might have encephalopathy, you might have ascites, you might have varices, and you might have had, bleeding from those in the past. And so that's sort of that shift from compensated to decompensated, and sort of the difference between the two.
Great. Yeah, and I think you alluded to what are some of the complications that we see in our cirrhotic patients. We can see that these patients may develop ascites, they may develop jaundice, they may develop esophageal varices, and then hepatic encephalopathy is another common complication that we can see in our decompensated cirrhotics. And then, of course, finally, kind of what we need to screen for in all of our cirrhotic patients, whether they're decompensated or compensated, is HCC. We should be screening all of our cirrhotic patients for the possibility of hepatocellular carcinoma. And so that is another possible complication that we can see of cirrhosis.
Yeah, absolutely. I agree with you 100%. And probably one of the biggest ones. I mean, I spend a lot of time with my patients, especially the newly diagnosed cirrhotics, going over that and explaining the risk of hepatocellular carcinoma, the importance of getting screening, ultrasound, and alpha fetoprotein every 6 months, and why, and the fact that it's a cumulative risk every year. So the longer you have cirrhosis, the higher your risk each year of developing HCC is going to be, and really trying to hammer home the importance of that screening for obvious reasons. If we find a lesion, if we find something that looks like HCC, the earlier we catch it, the better. And the more options we have to treat it, whether that be liver transplant, whether that be local regional therapies, versus catching it late. It's advanced. Perhaps there's portal vein invasion. Maybe there's extra hepatic spread. We've got metastatic disease, and then really limiting us to more systemic type therapies.
Agreed. One of the takeaways that I get from listening to you talk, Patrick, is that there's a lot of education that goes into educating our patients on all of these possible complications, how these disease states can affect their liver. And so I think as APPs, that's a really great way that we can improve patient care is by educating these patients.
Yeah, for sure. I mean, and this from your own practice. You've been practicing for a while now too. It's a lot of, we spend a lot of time educating, especially those new patients who maybe are just finding out that they have cirrhosis, didn't know it. We spend the bulk of our time educating them on what is cirrhosis, what to look for, such as complications, as we talked about. What are the screening things we need to do? The ultrasounds, the alpha fetoproteins, checking the MELD score, upper endoscopies, et cetera. And I think a very important part of that is for them to recognize things to look for, so that in between those visits, they or their family members know what are the signs and symptoms to look for. So if something does develop, they need to reach out to us sooner than waiting for, say, the 6-month appointment. They need to come back sooner or let us know so that we can address it, so that things don't get out of hand.
Great. I agree. Well, Patrick, this has been so informative. I think we covered a lot of things, and talking about understanding chronic liver disease and cirrhosis. So I thank you all for joining us this afternoon on this GHAPP podcast, and we hope that you listen in for some more learning.